Hello, everyone. It's Blaine Penny here from MitoCanada. Oh, we've got, looks like we've got actually Mark joining with us here. Sorry, we're a few
Hello.
minutes late. Oh,
Sorry. I'm
hello.
sorry. I got a page from the ICU. Wouldn't you know it? Right at the same time.
There you
We're in
go.
a
There you
silly
go.
issue.
Okay. Well, Dr.
All right.
Khan, we're just going live. We had held off here. I was just about to apologize to everyone. So you're joining just as we're broadcasting live. So
Okay.
welcome everyone to the webinar today, and appreciate you taking the time to learn more about the impacts of COVID-19 on the mitochondrial patient community. And special thanks to Dr. Aneal Khan out of Calgary here at the Alberta Children's Hospital. And we've got Dr. Tarnopolsky, who's in a procedure right now and going to be joining us shortly. So things are very dynamic with what's happening in the hospital right now. And Dr. Khan mentioned he was just called away to the, I think, to the ICU as he was on his way to his computer. So it's going to be a bit dynamic here today, and hopefully we can have one or the other to cover the questions. So let's go through a few opening remarks before we jump into the Q&A and a bit of housekeeping here. Certainly we all know this is unprecedented and challenging times. There's a lot of questions around understanding the coronavirus, in particular how it affects vulnerable populations and people who have chronic illnesses like mitochondrial disease and metabolic diseases. To date, I'm only aware of one family that's been impacted, a Mito family that's been impacted as of Monday. There was one case of a family in the United States when we were catching up with some folks from the United Mitochondrial Disease Foundation. And I just also wanted to note that we have received some requests for interpretation and closed captioning for people who are hearing or visually impaired. So we do not have interpretation, unfortunately, but we are going to work on closed captioning for the video production that we post to the website later and share. So that is something that we're very conscious of, and appreciate that being brought forward. So a couple things in terms of how the video function and the format for today. So we have disabled the chat function on the bottom of the screen. But if people have questions in real time as we're going along, everyone is muted, but please use the Q&A button at the bottom of the screen, and then you can submit your questions through there. And Gail Baxter, who looks after our communications, will be capturing those questions and passing them through to me in real time, and we'll add them to the list. And what we've also done, we've had quite a few questions in advance, so we've taken those and grouped them into categories. So we'll work through those categories, for instance, about coronavirus itself, and then we get more into like the risks to patients, et cetera, et cetera. And also when you do submit a question, it will come through. I'll just read the question and I won't mention the name. It will be anonymous. So we've got Dr. Khan here, Dr. Aneal Khan, as I mentioned, from the Alberta Children's Hospital. He is a lead metabolic genetics physician at Children's. So Dr. Khan, I'll turn it over to you to introduce yourself, and then we can jump into the questions from there.
Hi, thank you very much, Blaine, and to MitoCanada for the invitation to address these questions. And I'm a medical geneticist and pediatrician. I deal with a lot of mitochondrial disease and a lot of metabolic disease, and will do my best to address your questions with what I'm calling factual information. And you may hear differences of opinion, as you always will with any group of doctors. I'll try to give what I know and interpret as the facts for this information to help you.
Thanks, Dr. Khan. Really appreciate you making the time, and I know it is a crazy time for you in the hospital, and so yeah, thank you for being here and on behalf of our whole patient community. So I'll start out with the first couple questions are really around the coronavirus itself, just to set the stage. So the first question we have is how do we know the difference between the regular flu, seasonal allergies, and the coronavirus?
So it can be hard to tell the difference between other types of viral infections and coronavirus type 19 or COVID-19. And it's people are using different names. But the only real way to know is to do testing. But we are seeing a pattern with coronavirus in that people can have a fever and the shortness of breath symptoms. Some of them are very similar, such as cough or sneezing or runny nose, or even some abdominal pain. But it may make some people sicker than the flu does. The degree of infection may be worse, but you wouldn't be able to make a diagnosis if you saw somebody on the spot of whether they had COVID-19 or some other type of viral infection. One thing that might help is if somebody has had immunization, it's less likely, but not impossible, that they have picked up a flu. So I think that piece of information might help as well.
Okay. So the next question we have is around how does the coronavirus affect the lungs?
So it has different ways of affecting the lungs. The most severe way it affects the lungs is actually it can cause the body to have a reaction in its attempt to try to fight it, which is it's the body's immune response. And that immune response can damage and cause leakage in the tissues of the lungs. So you think of the lungs as you imagine a balloon, and you put oxygen into the balloon, and then it has to get across the wall of the balloon to the air outside. And if you produce a leak in the balloon, there's no way you're going to blow it up. So you can't expand the lungs, you can't get oxygen inside the lungs, and the system of getting oxygen to your blood doesn't work. So that's called adult or acute respiratory distress syndrome, or ARDS. And it's a very severe complication that's seen in a small number of people with COVID-19 infection. The other ways are it can cause a pneumonia, which is a buildup of fluid and immune system cells in the lungs, which makes it hard to breathe as well. And sometimes you can get bacteria in those regions, and you can get another infection from a bacterial cause. It can also cause some general reactions in the nose, in the back of the throat, and the airway, where the body is trying to respond to the virus being present and launches a milder response to try to deal with it. So, and then there's direct damage to the lung tissue itself, because when the virus gets into cells, it will use the cells to make more virus, and in doing so, destroy the cell at the same time. So there's some destruction taking place in the cells.
Maybe it's a good time to ask this question here. So there is a question related to pneumonia, the pneumonia vaccine. So a lot of people are asking about getting the pneumonia vaccine as a precautionary measure. And what are your thoughts on that?
So the pneumonia vaccine won't provide protection against COVID-19. So that part needs to be clear. What it might have some role in is if somebody got COVID-19, and if they got a bacterial infection, such as a pneumonia on top of that, if they were immunized, that might provide them with some degree of resistance to getting the pneumonia infection, but not the COVID-19 infection. So the COVID-19 can cause a pneumonia on its own. They wouldn't be protected against that. There are certain vulnerable populations that may be more prone to getting what are called streptococcal pneumonias, because that's what that vaccine is really for. And those would be people who may be immunocompromised for specific reasons. And I know we talk about mitochondrial patients being immunocompromised, but many aren't really in the classical sense, meaning their white blood cell count is okay, their antibody production is okay, they handle viruses okay. But there may be some, such as in Pearson syndrome or some of the deletion syndromes, where the bone marrow is not working as well. as one would expect, that may have some immune compromise, or some people, for whatever reason, have had a spleen removed, because having a spleen removed puts you at higher risk for infections from pneumococcal bacteria. And there's a longer list, which we won't go into here, but there are reasons which can increase a person's risk for getting pneumococcal pneumonia, and those people, in many cases, may have received the vaccine anyway. So it's also one that we use in transplant patients, for example.
Okay.
So many reasons for it, but it won't protect against COVID-19.
Okay. So we have a bit of an extension on that question as well, relating to pneumonias and aspiration risks. So it says, if your child is prone to respiratory infections or pneumonias due to aspirations, are they more at risk? And would they have a more severe response to COVID-19, in your opinion?
Okay. So the last part, do they have a more severe response? I don't think there's any data that allows us to say whether, if somebody is chronically aspirating, that they're going to get any worse of a pneumonia with COVID-19 versus something else. But if we take a step back to answer the first part of that question, COVID-19 is an infection you get from touching a surface that has the virus on it, or certain types of contact with people who are infected. You do not get COVID-19 because of chronic aspiration. So the risk question has to do more with exposure than just somebody who's chronically aspirating. They, in and of that issue itself, are not higher risk for getting COVID-19 infection. They could be chronically aspirating their entire life. If they don't come in contact with COVID-19, they're not going to get a COVID-19 pneumonia. So getting the infection or having a risk of getting the infection has more to do with the exposure. Right now, we don't have a lot of data on what the factors are where you could resist getting the infection one way or another. But even with other infections that those patients get, other viral infections, they're still getting them from the community or from a source. So somebody may be getting a lot of infections. The way we would normally look at that is it's not necessarily because of their immune system, it's because they keep coming in contact with a number of viruses. So maybe they're in a very big daycare center, or there's somebody at home where they work in a place that sees a lot of infections. It may not be the person themselves that is producing that risk, it's the contact.
Okay. Appreciate the clarity on that. So the next question is someone who's impacted and works in the healthcare system. So the question is, we have a patient who has a mitochondrial myopathy and works in the healthcare system. The patient does not have direct contact with patients, but coworkers do. How does the patient distinguish between symptoms of coronavirus or symptoms of a mito flare-up?
So, of course, mito flare-up is a big term.
Mm-hmm.
A lot of what we call a mito flare-up may have to do with some other infection. So it can mean different things to different people. If you have a flare-up, which, keeping in mind, could mean any number of different things, the only way to distinguish that from an infection is actually to test for the infection or to look at the symptoms. So a lot of people may go through periods of increasing muscle fatigue and weakness, but coronavirus produces respiratory systems in addition to that. It's unusual for it just to produce fatigue-like symptoms. It's not to say that it can't, but that's not usually what it does. It usually produces the respiratory symptoms. So if you're not having any respiratory symptoms, yes, it's possible that your body may be responding to coronavirus that's not in the symptomatic stage, but most likely it's actually not that being the cause. It could be another virus, but again, like I said, the only way to distinguish one virus from another really is to test for it. The other type of flare-up that might happen is a neurological one, such as encephalopathy or worsening of seizures or things like that. And again, it won't be an isolated neurological component. There should be a respiratory component usually that goes along with it.
Okay. And so some of these questions may have a bit of overlap, but this is another question around the risk side of things for patients and severity of risk. So the question is, does the coronavirus put a mitochondrial disease patient at a higher risk, or does risk depend on the severity of the disease in the patient?
It's actually more to do with the latter. So we know with coronavirus, COVID-19, we know in some people the infection is severe enough that they die. It's a small percentage of that's what happens, but most people are able to tolerate the infection. So the severity is difficult to predict in different people. I think in general, if one's health is not good because of various reasons, then any tolerance of any type of infection is more difficult. But we can't predict at the beginning if somebody has coronavirus how bad it's going to be.
Okay. Next one's is specific to Kearns Sayre syndrome. So the question is, my daughter, who's 13, was just diagnosed with Kearns Sayre syndrome last week. She is not exhibiting a lot of symptoms at this point, except with her eyes. She has ptosis, weakness in the muscles in her eyes, and retinal pigmentosa. I am wondering if she's as much as a risk to COVID-19 and other things as someone else who's exhibiting more symptoms or seems more sick.
So again, the risk here, we have to separate risk of severity of infection versus risk of exposure. Risk of exposure is not different if you have Kearns Sayre syndrome. You have to come in contact with the virus. There's nothing about Kearns Sayre syndrome that puts you at higher risk for coming in contact with the virus. But if you get the virus, are you at higher risk for a more severe infection? In general, one might say yes, because we know with Kearns Sayre syndrome, if you look at sort of the classical type, you have weakness of the heart, you can have neurological issues, you can have muscle weakness, you can have effects on the bone marrow. So yes, if you get the infection, it might make you sicker. But coming in contact is the same as the general population. If you locked yourself up in a room and never left it, you wouldn't get exposed just because you have Kearns Sayre syndrome. That's not the reason for the exposure. So that's why the isolation measures, the hand washing measures, all those other measures are so important, because those are things where we can control exposure.
Yeah, that makes sense. So our next question is, some mitochondrial disease patients are taking mast cell stabilizers or large doses of antihistamines. Can taking these medications make you more susceptible to contracting COVID-19 or make an infection to COVID-19 more severe because of these medications? So a bit of a different spin on the last couple of questions, I guess.
Well, we don't have any data to suggest that actually just taking those medications increases your risk. Again, exposure to the virus was what brings the infection, not how much mast cell stabilizers or antihistamines that are being taken. That does not increase risk of the transmission of the virus into the body. Now, of course, on its own, it's hard to answer that question because it does depend on the physical health of the individual. But taking the drugs in and of itself, as far as we know, there's no evidence to suggest it confirms a higher risk of what we call infection transmission, which means if you touch a table and it has coronavirus on it and touch your face, there's no data to suggest that taking those medications means you're more likely to pick it up.
Yeah. Yeah, I think this is still such early days in understanding so many of these nuances and predisposed conditions, I guess, that data is just not there yet. And we'll learn a lot more about that in time, I guess. The next question is a bit more about the demographics. We hear a lot about, certainly in mainstream media, that it tends to affect more of the older population. And now we're seeing a bit more about, well, don't let your guard down. Young people are getting impacted. So the question here is, we hear that children are less impacted by coronavirus. How does that affect children with mitochondrial disease?
I don't know that it's any different. I don't think we have any data that it's any different. I think it would be risky to say that children are more resistant. We don't have data to show how many children got infected and how many resisted it versus older adults. So, but right now, what do we tend to do in our society? We protect our children the most. And that may be a factor why we're seeing less transmission of infection, especially in situations where you have school closures. For example, in Calgary, a teacher tested positive. If you could imagine, if the schools were still open, there would be a risk if that teacher was working in a classroom of exposing other students to it as well. So there are various reasons why we may be seeing lower infectivity, lower numbers in children right now. I don't know that has anything to do with a protective effect of being a child or any worse of an effect of being a child with a mitochondrial disease.
Okay. So some questions here about exposure, doctor visits. So the first question here is when it comes to doctor visits, what are the options for patients, and should they, so if they have appointments that are scheduled, I'm guessing a lot of those are being canceled now, and if physicians need to connect with their patients, they're probably doing it over the phone or virtually via telemedicine. What's your advice to people who do still have appointments that are scheduled?
So certainly in Alberta, all scheduled appointments have been canceled. So patients are only physically seen if it's urgent. When you look at an average appointment for a mitochondrial patient, there may be medication renewals. One may review diet advice. In percentage of cases, the physical exam may reveal information that you can't get another way. But that's not the usual reason for the routine appointment. So there's many things in the routine appointment that can be accomplished through a telemedicine visit. And right now, we don't think the risk of exposure by going out in the environment may not be the hospital. It may be the route you take to the hospital, where you stop off, and all those other things that you do, or if you use public transit, using public transit. The risk of coming in contact with the virus obviously goes up as soon as you leave your home. And so is that worth a medication renewal? Is it worth a physician just going through an overview and asking a bunch of questions? And I think I agree with many people in that it's not worth the risk. So scheduled visits should be attempted in a teleconference or another visit. And then the team can assess whether or not physical visit is required. So, I mean, out of the 250 or so mitochondrial patients that I'm following, just to give you some numbers, there isn't a single one right now I've triaged as requiring a full physical visit for some purpose. Having said that, there was a child that came to the ICU yesterday that we did a stat muscle biopsy on. So each situation has to be handled differently, but I think it's a small minority that will actually need a physical visit. Those other routine visits and checkups, I think, are better performed through a different mechanism.
Okay.
But you'd have to check with your clinic to see how.
Okay. There's a couple of questions here now around going to the emergency room. So the first one here is, just wondering if we catch COVID-19, if we give the same protocol to ER physicians that we already have for instructions in times of sickness, or is there additional information we need to be made aware of? Any medications or special treatments that will be needed for someone with a mitochondrial disease? Anything to avoid?
So we need to consider that this is a viral infection, and it may not be severe in some people, and there is no drug to treat the viral infection itself. So it may not be any different than the standard illness management. You also want to consider going to the emergency room, not precaution, but if you actually have a real emergency. So you may have to discuss with your physician whether any changes are being around triaging what's a real emergency versus an issue that maybe normally you might go to the ER for, but in this situation that might be a different decision. So the actual situation, if a child has a COVID-19 infection who has a mitochondrial disease and arrives in the emergency room, is not really something that can be put into a protocol. You can't have one set of instructions that suit everybody. The physician, ER physician seeing the patient should communicate to their specialist what the situation is to see if something needs to change. But certainly in Calgary, that's something we do with every case anyway. I rarely use protocols in the emergency room because how can one admission always be the same as the second admission? Even in the same patient, it can vary quite a bit. Now, in bacterial infections that are picked up, if somebody shows up with a COVID pneumonia and they're making a choice of antibiotics, and they should review some of those with the metabolic doctor to see what the choices are. But at the end of the day, if you have a severe pneumonia and the testing shows that certain antibiotics are best at killing it, usually what I say is go with the choice of the best antibiotic versus a relative risk of maybe a potential hearing issue, mitochondrial disease, or some other issue. You have to kill the infection first. If you don't kill the infection, you won't have to deal with the side effect of the antibiotic. That's going to be a new time. And I see Dr. Tarnopolsky, hi Mark, is here.
Just made it.
So Blaine, is it okay if we hand over as we're trying to juggle multiple?
Absolutely. Mark, are you good to go here for the next, say, 45?
Yep, it came down to the wire, but thank goodness all the LPs went smooth as silk, so we're good to go.
Excellent, excellent.
Awesome.
Well, Dr. Khan, signing off here. Thank you once again for stepping in and sharing your knowledge and insights to answer these questions. And it's great that you and Dr. Tarnopolsky can tag team here. So we've got it covered. So thank you.
Take care, everybody. Bye-bye.
Bye.
Thanks, Aneal.
Okay. All right, Mark. Most people who are watching probably know who you are, but if you wouldn't mind just giving a brief introduction of yourself. So Dr. Mark Tarnopolsky is from McMaster. Mark, take it away.
Good. Yeah, so I'm a neuromuscular and neurometabolic physician at McMaster University. We see a lot of patients with different metabolic disorders and muscular dystrophies. So we're obviously getting a lot of calls because many of our patients, especially with the muscular dystrophies, have respiratory issues around the whole COVID-19 issue. And I'm sure that's what most of the questions are pertaining to. So again, for everyone, it's important to know that this is a changing situation. So it's not that we are ill-informed, it's that the recommendations from the experts change. So for example, last week they were saying that people shouldn't be wearing masks, and last night on the CBC to infectious disease agents, physicians were suggesting that we should be wearing masks when we go out. So these things do change, and it's important for people to listen to good advice. There's a lot of misinformation on the web, but generally something that's coming through CBC. They're interviewing top infectious disease doctors, and the advice that you're going to get through those more standard channels, I think you should be following that advice and paying close attention because things do change from day to day. But as much as we know, we can certainly try and share that with you today.
Great. Thanks for that, Mark. So we were just talking about, we've grouped the questions into categories here, Mark. So we were talking a little bit about visiting the ER on the previous question, and another question on that one as well. So the question is, many patients visit our ERs, have problems with fevers or feeds, those types of things. So the question is, when should they go to the ER, and what advice would you provide before somebody goes to the ER?
Well, I think generally the choice to go to the emergency room is not one that people take lightly, and I think most patients know when things have crossed to a point where you need to go to the ER. So I really don't think people should be changing where that bar is based on this and say, oh, well, because of COVID-19, I'm going to wait till I'm a little more sick than normal because, with mitochondrial disease and indeed with many disorders, if you get sick, things can change very quickly. So I think whatever bar that you've used to say, this is time I need to go for my son or daughter, or yourself if you're an adult with mitochondrial disease, I think you still should use that same bar and go in. Because I've seen healthy 19-year-olds when I used to do the intensive care unit, in a couple of hours end up on a ventilator with standard bacterial pneumonia. And so you don't want to delay things too long and just be afraid of the fact that COVID-19 exists in our community, and you should just go in. Now, I heard Aneal also mentioning when you do go in, is there a standard protocol? I think the protocol is what Aneal and I generally do, and that is, this is our phone number. Get in touch with us, and if not, a metabolic physician on call is going to know all of the general principles. And the ER docs I found are generally excellent at calling us, because if we give a specific standard protocol, it might be very different depending on the circumstances. So I prefer to see what the situation is with a given individual, work with the emergency doctor to provide information. And sometimes it's like, but what you're doing is great, there's nothing more that we would suggest. And as Aneal was pointing out, if there is a choice in an antibiotic that might be more or less toxic to the mitochondria, those are things that they might not know, and that's where I think we could be helpful in that regard.
Okay. So the next question is maybe a little further down the road, but it's around isolation and given the patient community is in general immunocompromised. So the question is, for mitochondrial patients with compromised immune systems who have been placed in self-isolation for their protection, how long do you expect that they will need to self-isolate beyond the general public? And how will they know when it's safe to go out again? And I know that you had mentioned off the top, this is changing, there's new information coming, and that may change in time. But given where we are right now, what advice would you provide in terms of being extra cautious for someone who's immunocompromised?
Yeah, I think a couple of things. Certainly, if someone is forced to self-isolate for 14 days, that's generally the time frame. I would stick to that number, and I don't think that changes. As best we know, that's about the maximum time of incubation, and if you're clear in 14 days, you're unlikely to have this infection. And that's certainly, I don't think, any different whether you have mitochondrial disease or not. So the bug isn't going to live in you for longer. I think in general, the most important thing really is an ounce of prevention is worth more than a pound of cure. And really, in my patients who I would deem high risk, and what I mean by high risk would be someone on an immune suppressive drug, and we have very definite guidelines for that, and that's not very common in mitochondrial disease, but we see it in other disorders. Some people with mitochondrial disease, not many, but some can have a compromised immune system, and if there's been a history where someone is more prone to infections because they have a fairly severe mitochondrial disease, I think we would have to put them into a higher risk category. If there is respiratory issues, so for example, if someone's using bipap, which is a special respiratory support, if someone's had numerous chest infections or previous admissions for pneumonia, we consider that person to be at high risk. So I think in those situations, I would prefer, and my recommendation is for that individual to self-isolate. So by that, they would not be the ones going out as best they can to go shopping, even if it's only once every 2 weeks. So a designate, so if it's a child, it would be a mother or a father, would be the one that would go shopping. What we would then do is, what my wife and I do, and we recommend, is have one space that is cleaned off. So for that, you can use an antiviral like the Clorox or something like that. If that does run out, there are poor man's versions, which should work fairly well. So Clorox bleach mixed in water is known to be a good antiseptic, and we use that actually in the lab to kill viruses and bacteria. So adding bleach to water generally about a 1 to 20 dilution, or using any ethanol product that's more than 70%. So wipe down the surface, nice hard surface that doesn't have pores in it. So in our lab, we had these old benches where the coating would come off and things can sink in there, and that's dangerous. So we want a nice hard surface like a Corian or a granite surface, all right? Then what you do is you put your groceries down, and what I would suggest is canned goods and things that are hard like that, you can wipe those down with Clorox, those little wipes that you have, and then put them into the cupboard. Again, on a hard surface, the best evidence that we have is that this virus can only live for about 2 days. So once something's been in your cupboard for 2 days, from every bit of evidence that we've seen, that alone should kill the virus. It can't survive much longer than that. So certainly the things that you're going to eat sooner within the first 2 days, make sure those are definitely wiped down. Again, I would not want the child to be going in, or the immunocompromised person to go into that cupboard and take that out later for at least 48 hours. It's a little tougher for things like apples and oranges and these sort of things. What they say is that generally warm water and soap, if that's feasible. I mean, that's going to be tough to wash your oranges and stuff, but if you could do that and then rinse it in water and then put them away, I think that's probably prudent. We don't know how long the transit's been from someone picking that. And as we know, oranges and these sort of things are coming from California. And we know that there's a much greater incidence in California. So I would certainly say cleaning those off would make sense. It probably even makes sense for the mom or dad or somebody else to peel the orange so that anything on the surface would not go to the individual, and then put those things away. So those are some things that we think are reasonable when you go shopping. And then when you're done, wipe everything down again, okay? Washing your hands is clearly very important. So even if you have that hand sanitizer, they say that that's not as good as a good hand wash. And generally with your hand wash, you want warm water, you want our hands covered and go to about this level of the wrist, and 30 seconds or so should be sufficient. And then drying with a paper towel would make sense afterwards. So those are some of the general things. I think it's prudent as well, if there's someone isolating or you want to isolate them at home, that the person who's, for example, changing diapers in a child or having most direct interaction, that you keep that as the same person, and that person should be different than the person, if you can, who's going out to go shopping or who's going out to go to work. It just would lower the statistical likelihood of bringing something into the house that could then infect the child or the adult with mitochondrial disease.
Okay, excellent. Those are great tips and reminders, I think, for some of the key things that we know already that are key things for care and prevention here. So the next one's around fluids and hydration. So is it possible for someone doing IV therapy 2 times weekly who has increased anxiety during this time, should they increase their needs for fluid, or would their fluid needs increase?
Not specifically at all. Just being more stressed or anxious is not going to change your fluid needs in any way, shape, or form. No.
Okay. Next question here is around people coming in and out of the home and around use of PPE. So the question is, I assume nurses and PSWs coming into the home should use PPE. There does not seem to be standards for in-home supports in Ontario. We are providing masks, etc. My son does not leave his home, but may have up to 10 different providers coming in, all with clients and families, or coming in with who have interaction with other clients and families.
Yeah, I mean, these individuals should be following all the precautions that we would, and that is, once you leave that other place, you should be washing, cleaning, sterilizing. When I get in the car, I clean, sterilize my wheel and everything. They should be doing that when they arrive at your house for their own protection. Generally they're going to be using something where they touch the door, clean afterwards, clean when they come into your house. So bottom line is, anytime you touch a surface, you should be cleaning your hands afterwards. And you should not do anything after you've touched a surface until your hands have been cleaned. Because as far as we know, the #1 transmission is touching a surface. So if someone doesn't, and you see them come into your house and they don't clean their hands, I think it's not impolite to say, would you mind please cleaning your hands? I think most people would do that. I think given what I saw last night from the infectious disease doctors, and I think any nurse coming in would probably be starting to do this now. They should be wearing a mask. I also think that the child who's receiving the care, or an adult who's receiving care, it's prudent for them to wear a mask too, because if that individual, heaven forbid, were to sneeze, you're going to massively reduce the number of particles that are going to get into the person's nose and face if you had a mask on. If somebody happens to do that, I would definitely, take a shower, wash the person down as quickly as possible afterwards, if that were to happen, but hopefully that won't. But really, anyone coming into the home, it should be a professional caregiver. They should be well aware of what they need to do to both protect themselves and to protect others. Because if they don't protect themselves, they're going to be off work and potentially, could have a severe illness. So I would be shocked personally if someone were not following all of those recommendations. But please, if someone comes in and you think that they haven't washed their hands or whatever, just say, politely, would you mind doing this? I just would feel more comfortable.
Okay, no, good advice. So the next question here is, many of us with mitochondrial disease have myopathy and use BiPAP machines. And the idea of getting COVID is a real concern with compromised respiratory systems already. Is there anything that you would suggest to this group of patients if they were infected with COVID? And is there anything else that they should do?
Yeah, again, someone on BiPAP is definitely someone in high risk. So like our SMA patients, I was just injecting SMA patients right now, so I apologize for my attire. But these children all have compromised respiratory status, and we go through all of the things that we've just been discussing about making sure that they are as protected as one can possibly be. Certainly if you were to get COVID and you had a BiPAP, I just thought about this now, what you really should do is you should probably bring the BiPAP to emerge with you if you are going to emergency department. The reason for that is, depending on where things go, if it gets to the point where ventilators become a rare commodity, your BiPAP is effectively an external ventilator. And certainly that might be all you need to ride through, but they might not have BiPAP there. And if they didn't, you might have to go onto a ventilator, which may not even be available depending on how bad things get. So certainly if you are ill and you think you have COVID-19, you need to get that checked. And if you are going to emerge, I would wipe down very well and bring your BiPAP machine, because you may need it in the hospital. Again, we don't know where things are going to go, but that's probably not a bad recommendation to bring it with you.
Okay. So around this, the evolving of the masks and with the more recent information now that's saying that more people should be wearing masks. So there's a shortage of masks out there. So the question is, can we make our own masks? And if so, what types of materials should we be using for that? What are your thoughts on that?
Yeah, I think anything's better than nothing, and I think in life sometimes there's the ideal and then there's a compromise. So if you cannot get a mask, I'll just show you here. So I just came from the operating room. So this is a fairly standard sort of a mask. This is would be a tier 2 type of mask. The one up from this is the N95, which is more of a rigid sort of a mask. They say that's a little more restrictive. If you're using a mask like this, actually it's good that I have it here just to show you. With any of these masks, there's a little metal bar. What you do is you bend it to fit around your nose, so it's a nice tight fit, as tight as you can here, because that's where the stuff could go in. And then these wrap around your ear. So make sure that it's really nicely, snugly fit across your nose, and pinch it in, because that's where the air is going to get in, which contains the particulates. If you don't have something like this, just give me 1 sec. I think I've got one here. Sorry, Blaine, I don't have my MitoCanada buff.
Well, yeah, the buff, yes.
Yes, but honestly, I think, many of you probably do have a MitoCanada buff. Blaine, you can probably show us one. But a buff, B-U-F-F, is something that people may want to use. So what it is, essentially, Blaine is going to get us one and show us what it is. And these are things that we use when we're skiing. So a buff, here we go. Blaine's going to show us how to use a buff. So this is a cotton, or sometimes there's actually some other Velcro and other things in it. But he's going to show us how to put one on.
So it's just a head tube, but yeah, you can certainly cover yourself up and look like a bandit with something like this. But again, I'm guessing it would, like you're saying, anything is better than nothing to keep particles from dispersing. I'm assuming.
Exactly. So this would be an example of something that you could do, and I'm sure many of you have either a Team Mito buff, I hope, or any other buff like this. So this is going to help for you to prevent transmission to others, which is always a good altruistic thing. But if you're sick, hopefully you're not going to be going out and you're self-isolating. But the other issue too is that they do feel that there may be some airborne transmission. And although this is not as good as one of the masks, it's better than nothing. So what I would do when you come home too is, if you're the person designated to do the shopping, for example, and you wore this buff, which I would recommend wearing something now when you go out to Shoppers Drug Mart or whatever, when you come back, take it off, wash your face, preferably have a shower, and put that into the laundry. And I would wash these things with bleach as well. So put a little touch of bleach in, even if you might dull the color a little bit. So certainly that would be a very reasonable thing. And anything like a buff, even those bandanas and stuff that you cover, would be reasonable. I think the buff's probably a little bit better because it form fits fairly nicely around your face here. So, and these are available at most sports stores. If you go online, I'm pretty sure you can get these delivered to you. So it would probably be like buff.ca. And you could pick these things up. I think they're actually manufactured, aren't they, in Calgary?
Yeah,
yeah. A colleague of mine works for them, and they live in Calgary, but maybe they do it virtually. But yeah.
Yeah, but they're readily available pretty much at any sort of sport clothing store. Yeah, Mountain Equipment Co-op carry them as well. Yeah. Yeah,
I mean, a lot of the stores are open now, but if you go online, I'm sure you could look one of those things up. Yeah.
So if anybody has questions on that, obviously getting the N95 mask seems like the best protection, but if you're unable to get those, these are another alternative. So the next question here, Mark, is around exposure again. So if someone thinks that they've been exposed, what steps should they take?
Well, a person who's exposed, if you think you've been exposed, you've got to go into self-isolation. There's just no question about it. You do not want to risk yourself or others. And what you do is you take all of the self-isolation advice that is present through your local health advisory group and self-isolate. Do not go out into public. And if you think, oh, well, I just have a little bit of a fever, I was probably nothing, do not go out. If you have runny nose, fever, new cough, assume that you have COVID-19 until proven otherwise. Self-isolate. If you are starting to develop symptoms that you think are more significant, high fever, cough, etc., then you need to get tested. We need to capture this. And, in doing so, you need to call public health to find out what's the best way to get tested, because even that is evolving. I mean, I've even heard that they may even be coming to people's homes to do testing. There are places where you can drive and in a parking lot where there's no one else around, you can get tested, just like what you saw in South Korea. But what you don't want to do if you have just a fever or something like that is just to randomly show up at your family doctor's office, or if you have a bit of a fever, to go to emerge. Call first, find out where there's a place where you can get appropriately tested. But until such a time as you can get that done, assume that you're positive and self-isolate and just take those extra precautions. And also for those around you, make sure that whenever you're within 6 feet of that person's wearing a mask and or one of these buffs or something that's going to at least decrease their transmissibility.
Yep. No, good advice. Next question here is around immunoglobulin. So I recently read there was a test underway relevant to antibodies, specifically immunoglobulin M and immunoglobulin G, relevant to COVID prevention. Can you explain in layman terms of this potential?
Absolutely. So it came up yesterday, and today I have patients who receive immunoglobulin. So essentially, just to educate folks on what these are, when a bug comes in and you have any foreign body that comes into your body, so it's a virus or a bacteria, our immune system initially launches an attack against that. And the first immunoglobulin is called IgM. So the IgM essentially is 5 molecules with little forks on the end, and they float around. And on the ends of it, they recognize something new. So if it's something like COVID-19, the first time, there's not enough time for us to make enough of these and to get the secondary response to knock it down. But what happens is we're starting to produce these antibodies to recognize this new foreign invader. And then eventually, that's what immunity means. So once you've had COVID and you mount this response, these little antibodies float around, and we start to make something called IgG. IgG produced by something called a B cell, and those hang around as a memory to remember that you've been exposed to something. And then when something new comes, they're already ready to go. And they say, aha, COVID's here, boom, let's spit out cow loads of these IgGs, and let's kill this really quickly. So that's really the basis of immunity. So you get natural immunity by being infected, then your body goes through this process, makes your own antibodies. So they took advantage of that to come up with vaccines. And so the original vaccine essentially was to take an infectious agent, and obviously we weren't going to give people smallpox back when I got my injection in the 60s, but what they did is they took a smallpox virus, mutated it a little bit so that it couldn't replicate, and then when you get your immunization, you mount an immune response against it, first IgM and then IgG, and then you get these memory cells so that when smallpox came, we could kill it because we had the IgG. So what people are thinking is, could you take serum from someone who recovered, knowing that that serum contains IgG, which is floating around in the body, and use that as a therapy, and that's called serum therapy. The other way of thinking about it, which I was prescribing yesterday and we had to talk about today for patients with myasthenia gravis, is you can take donors' plasma and they can extract all the immunoglobulins. So the IgG and IgM get extracted, and that's called intravenous immunoglobulin. And you can infuse that back into a person. The problem with that is that those immunoglobulins would be a compilation of everything those 1,000 donors were exposed to. Given that it would have been prepared prior to the COVID-19 crisis, there would not be specific antibodies to COVID-19. Now, it would confer a little bit of generalized improved immunity to that person. And so a lot of our patients on high doses of steroids, we're switching them over to IVIG because it's a bit safer. It doesn't suppress their immune system and actually gives them a bit of an immune burst. So hopefully that answers the question.
Yeah, no, I definitely. So one of the other tests that's being developed right now is to determine who, like I think the statistic was about 20% of people who get COVID are asymptomatic. So now one of the next tests that's being developed is a blood test to determine if someone has been exposed to coronavirus and have developed the antibodies. Can you comment on what is the status of that blood test and any advice to the Mito patient community around that test and when it will be available, and any concerns with that blood test?
Yeah, no, it's a prudent test. So if people think about something that's been developed for over a decade now, is a pregnancy test, which is essentially the same thing. So what this is relying on is having, what they're trying to do is to have a capture antibody that recognizes that you have the antibody specific to COVID-19, and then there's a color or something that would light up in the presence of exposure to the antibody to the COVID. So essentially that's what they're looking at. So the whole process I mentioned where we start to generate these memory IgGs floating around, that's what these are looking for. They're very conceptually easy to make these assays, an ELISA assay, and eventually to get it down to a filter paper. Doesn't take long. What does take the time is to make sure that it's sensitive and specific. What I mean by that is, if you had COVID-16, I don't even know if there is one, but let's say a sister to COVID-19 and COVID-19, they're just a little bit different. And you want to make sure that this test is sensitive enough to say, I only bind to and report COVID-19, but I don't give a false positive to COVID-16. Other flus, for example, like the adenovirus, for example, look, somewhat similar. So you don't want cross-reactivity. And to really say that this is always going to call the disease when it's present, and you're never going to get false positives, that takes a long time to go through. And Health Canada and FDA don't want people to panic because you get a false positive, and they don't want people to have a false sense of security with a false negative. So making the test, easy peasy, lemon squeezy, but getting it to the specification that's required for us not to have false negatives and false positives is going to take a while. So probably someone's already developed these. I would be shocked if they don't have them developed, but we're going to have probably 4 to 5 months of testing on patients, positive and negative patients, to get those criteria. But I suspect by the fall, something like that's going to be available at the latest.
Okay. Yeah. No, it's important to get a sense of how many people have been exposed and what that, obviously things are changing so quickly, but that's going to be an important test here in within the next few months. So next we have here, Mark, is a challenge for a lot of families who have children who may have autism or spasticity and touch their face. So any advice around families that have children that touch their face a lot, and to help minimize the transmission if someone does come in contact?
Yeah, I think the concern for touching your face is, I just came from the OR. I went through 7 doors. So on the way through, and when I open a door, I'm always looking to clean my hands. But fortunately in the hospital, every door I open and close, there's hand sanitizer. And I've been doing this ever since SARS, so I'm very comfortable doing this. But if you forget, and then you just touched a door and went like this, and a person with COVID had touched that door and it sneezed into their hand, you're going to get it with a high degree of probability. So the point is that as long as you're following all of the best care guidelines to not bring COVID-19 into the home, and the kids touching themselves and all over the place, who cares? Because there's no COVID-19, so you can pick your nose, you can do whatever, and nothing's going to happen as long as there's no COVID on that child's hands. So I really think that if the caregiver has followed all of the guidelines that we and others have suggested, don't sweat the small stuff, and don't freak out if your kid's, touching your face or sticking their finger in their mouth or anything. Of course, we're going to want to wash their hands several times a day. Perhaps increasing hand washing in that child would be more reasonable. But most parents are probably doing that anyhow, because by the same token, forget COVID, what about bacteria that are floating around? You don't want your kid to get infected that way. So I really don't see it as a huge issue.
Yeah, it's that reminder how important it is just to keep it out of the house, right? And just it's about the exposure. And then obviously it's a secondary issue if there's an exposure, and we've talked about how importance of isolating and cleanliness, that type of thing. Next question here is an interesting one, Mark. It's around ibuprofen and Tylenol and any potential there. So what are you hearing about the use of ibuprofen? Some say it's not recommended for patients who contract coronavirus. Some say Tylenol. Do you have any thoughts on Tylenol and ibuprofen?
Yeah, I don't think there's enough information at this point to be definitive. So certainly, absolutely, if you have an allergy to something, don't take it. But at this point, I don't think we have enough to say absolutely don't use ibuprofen or don't use acetaminophen. I think whatever has traditionally worked for the child or the adult, I would stick with that for now. I really think that, these are tiny little, if anything, it's going to be an infinitesimally small increased risk. I really do not think that if you're exposed to X amount of COVID-19, whether you had ibuprofen on board or didn't, is really going to have a strong influence on whether you get it or how severe it's going to be. We just don't have enough evidence at this point. So I would really not sweat that one.
Okay. So there's lots of obviously scientists, researchers, pharmaceutical companies that are racing to find a vaccine or drug here. There's many tens of those in the pipeline being tested, going into clinical trials right now. Should should those treatments and vaccines or drugs become available, Mark, what concerns would you say in general should the mitochondrial patient community be thinking about? I'm thinking potential drug interaction, and I'm guessing also with clinical trials here, they're probably going to try and fast track to some degree. What concerns do you have once something does become available?
Yeah, I mean, certainly, from a vaccine perspective, as I mentioned before with my smallpox vaccine, we essentially eliminated smallpox because of vaccines. I had German measles, I had red measles, I had mumps. We didn't have vaccines back then. They were not fun. Fortunately, I didn't die. I had chickenpox. I thought I was going to die. All of those things are now preventable diseases. So certainly, I think first and foremost, if a vaccine comes out, and by the time it's offered to the public, it's going to have gone through safety to the extent that the benefits would vastly exceed the risk. The risk of this disease right now, it's over 5% of the worldwide population are dying if they're infected with COVID-19. That's incredibly high. Generally, flu at most is 1% or less. So this is a very serious disease. So certainly there's an anti-vaccine group out there. And I would say, you don't want to take it, that's fine. But if you want to save your life and those you love, if a vaccine comes, it's going to be at the level of safety that the benefits would vastly outweigh the risks. Now, shorter term, my suspicion is that that's probably at best, if we're really lucky, not going to be around until the fall, and maybe into the first quarter of next year. What may come sooner, people have heard of Tamiflu, I'm sure, which people use for some of the flus that come around, or ribavirin for RSV, which is another respiratory infection. So these are drugs that were designed to actually attack the virus. HIV, people probably remember when HIV first came out. It's an RNA virus, and some of the drugs inhibit the replication. The bugger there is our mitochondria that used to be bacteria, and they replicate in a very similar fashion. So some of the first HIV drugs actually were causing mitochondrial symptoms in patients who didn't have mitochondrial disease, and they were unmasking mitochondrial disease when they had that. Fortunately, a number of companies now have created a new generation of drugs which don't inhibit mitochondrial DNA replication, which is certainly encouraging. And I would suspect as they move forward, that same technology is going to be applied to this virus. And so I would expect that the risk to mitochondrial patients is going to be very low from taking these viral agents. We've learned a lot about what damages mitochondria and what doesn't in the antiviral field. And Gilead in particular, these companies, I think, know what's going to be bad for mitochondria, and they're going to be avoiding those in the drugs. But I think those are going to come first. I'd be surprised if something doesn't show some efficacy come September, October.
Next question is about exercise. So should people continue to exercise? Can it be vigorous? What would you recommend differently with COVID lurking out there now versus what you would recommend any other time, Mark?
Yeah, I think bottom line with exercise is we know that if you're used to exercising, it's good for you. We know that exercise is good for mitochondrial health. It's also good for anxiety. I know myself, I'd be a caged crazy person if I didn't, and I know you're the same, Blaine, if we didn't exercise. So I do get a lot of phone calls about people who are incredibly anxious. I look at my fellow support workers and I see a lot of anxiety. And certainly spending that time exercising, I think, is going to help to get your karma square, for lack of a better term. And I think it's important to not give up exercise. When you're out exercising, my only concern is if you go to a parking lot where there's tons of people, like you drive somewhere to a park and go for a run, and you go to a parking lot that's full of 500 cars. I think that's being shut down. Certainly Dundas Valley parking lots, everything's shut down there. But if you can go somewhere for a run, if you exercise outside safely, then by all means do it. Certainly running is a very safe thing. Cycling is very safe. And even if you pass by someone when you're on a bike, for example, and you're within 2 meters, the likelihood of them sneezing just as you go by is 1 in 100,000 sort of thing. So I think from that perspective, it's fairly safe. Certainly post-exercise, you're not going to be at greater risk of infection. And for what most people do, your immune system is actually better when you exercise. It's only incredibly high levels of exercise when someone's massively overtrained that there's evidence that you decrease your immunity. Otherwise, you actually boost your immunity. And I don't think there's anyone who's going to be exercising to that level. Not even you, Blaine.
No, I agree, especially with my bumped knee. That's a different story.
Got to get healthy for our race at the ball.
That's right. That's right. Hopefully it can still happen.
Mm-hmm.
Mark, we're winding down here, just looking through the list of questions here. Most of them have already been answered in one form or fashion, but maybe wrap up with one more that touches on the Mito cocktail and this concern, with shortages of maybe some of the cocktail components. The question is, should people be increasing dosages from a preventative standpoint? And if they end up in the ICU, is there anything different that you would recommend as it relates to the cocktail?
No, bottom line is if you end up in the intensive care unit, there's a lot of other things you got to worry about versus the cocktail. One, the cocktail has a long half-life. So creatine, it's about 30 days in your body. CoQ10, again, we store a lot of it in our body. So these things are around for a long time. So I just don't want anyone to have anxiety that if you're missing it for even several weeks, that's going to be much of an issue. And certainly compared to an antiviral and antibacterial, supportive care, fluids, all of those sort of more acute medical issues, the cocktail pales in comparison. As I call it, it's icing on the cake. But I would not want anyone to get anxious thinking, oh my God, I've missed a day or two, and then to do something rash like, go to 5 stores looking for alpha lipoic acid, for example. I think you'd be at far greater risk trying to find alpha lipoic acid and going to 3 or 4 health food stores, if they were even open, or a drugstore, than you would missing it for 2 to 3 weeks. And certainly when you come into the hospital, when you're recovering, fine to get back on it, but I have no concerns at being off it for weeks to months if you had to.
Okay. Mark, that's great advice and great insight all around. Just want to say thank you for making the time. I know you're running around with lots of things that are high priority for you right now, and you're on the front line here and there. So thanks for taking the time to answer the questions and support our community here. And just wanted to remind people that we will be posting this webinar live, or not live, but sort of a recorded version of this on our social channels as well on our website. Also encourage you to, if you haven't signed up to our closed peer-to-peer Facebook group, it's a great opportunity to help support each other and answer each other's questions and point each other to information that's already out there. And also, we've been in discussion with Mark and Dr. Khan, as well as Dr. Ingrid Teen, about answering some of these questions and having some FAQs that we've already gone through here that we may forget or may want to share with others in the community. So one of the things as a takeaway, I think, from this webinar was we'll extract some of those key questions and come up with a Q&A as it relates to COVID to better help you and provide sort of one source of the truth here for our Canadian Mito community. And just to close out, I just want to say, this is a time to look after ourselves, to look after each other. It's a very unprecedented time in terms of what the future holds and how long we're going to be cooped up and in isolation. It's hard to say. Certainly recommend developing a healthy routine at home, and this is going to be the norm for a while. So let's be cognizant of that. Let's be cognizant of our health, both physical and mental health, and try and stay positive. And definitely, just like other hardships and challenges in our lives, together we will get through this. And And we'll certainly be circling back as we get more information, or as information changes. We plan to do other sessions like this with Mark and other physicians, and maybe some other specialists that may be in relation to other areas of concern that may come up, or that others bring forward, in the next month or two. So just stay tuned with that. Keep an eye on our website and social channels for that information. So thank you, everyone. Keep well, stay healthy, and stay positive. Thank you.
Thank you, Blaine.
Yep. Bye now.
Bye-bye.